Hello, my name is Samira McKee, and I, along with Jonathan Wong, will be presenting a case on histoplasmosis masquerading as malignancy, a rare cause of hypercalcemia. Histoplasmosis is a fungal infection caused by Histoplasma capsulatum, which is endemic to the Mississippi and Ohio River valleys. The disease commonly presents as a respiratory illness, however, it can also present with a broad range of symptoms, from asymptomatic to serious disseminated disease, with multi-organ involvement given its hematogenous spread. Due to its broad range of presentations, it is often forgotten on initial workups. Here we present a case of disseminated histoplasmosis, whose symptoms mimic cancer without apparent lesions on imaging. The patient is a 49-year-old male with a past medical history of hyperlipidemia, end-stage renal disease status post-deceased donor renal transplant in January of 2021, secondary to focal segmental glomerulosclerosis, hypertension, and depression, who presented to the hospital with fever, nausea, vomiting, and a 35-pound weight loss over a 1-month period. The patient was found to have acute kidney injury on renal transplant, along with hypercalcemia with a calcium of 14.5. Hospital course was complicated by daily fever, which prompted a workup for occult infection and malignancy. Pan-CT scan on initial presentation demonstrated no evidence of metastatic disease or clear source of infection. Multiple myeloma workup was negative. Given his nausea, vomiting, and weight loss, the patient underwent EGD with duodenal biopsy. Duodenal biopsy was significant for fungal organisms as seen in Figure 1, and granulomatous inflammation as seen in Figure 2. Stains and morphology were suggestive of histoplasmosis, and the patient was promptly initiated on IV amphotericin B. Lab work later showed positive histoplasma antigen, histoplasma mycelial antibody, histoplasma yeast antibody, and elevated fungitel. Bone marrow biopsy demonstrated granulomatous inflammation consistent with disseminated histoplasmosis. The patient completed 7 days of IV amphotericin B and was later transitioned to itraconazole and vitamin C as an outpatient. Serum calcium levels normalized within 10 days of treatment for histoplasmosis. Granulomatous diseases, including histoplasmosis, must be considered in cases of hypercalcemia and recurrent fever. Although the majority of histoplasmosis infections self-resolve without treatment, the infection can become latent with potential for reactivation. Once histoplasma makes contact with the host T cells, lymphocytes activate macrophages, allowing the host to control the infection. Despite this, there may be remaining foci of viable H. capsulatum in various organs that may reactivate even if the patient has not returned to the endemic area, and especially if the patient becomes immunocompromised. Our patient possesses several risk factors for disseminated histoplasmosis, including renal transplant status and employment as a truck driver. Although less common, Texas is included in the region that is endemic to histoplasma. Therefore, he is at risk for reinfection as well as reactivation of prior infection. We theorize that he may have been infected in the past when visiting an endemic area as a truck driver and later had reactivation of latent infection when he became immunocompromised following renal transplant. It is recommended to continue monitoring calcium levels as worsening of hypercalcemia with initiation of antifungal treatment has been documented. Additionally, co-administration of vitamin C with itraconazole has been shown to increase the oral bioavailability of itraconazole. In conclusion, histoplasmosis can present with a wide variety of symptoms ranging from asymptomatic to mimicking malignancy. Therefore, diligent workup is needed to make the diagnosis. Early detection is warranted for successful treatment of histoplasmosis. Here we present a case of disseminated histoplasmosis mimicking malignancy with hypercalcemia and weight loss. The patient was treated with IV antifungals with favorable outcome and then transitioned to oral antifungals as an outpatient. Clinicians should hold high suspicion for granulomatous disease in patients presenting with hypercalcemia and fever of unknown origin, and should also consider the possibility of reactivation and/or reinfection of histoplasmosis in immunocompromised patients. Thank you for listening to our presentation.